homogeneous, that is maintained in the normal immunity for protect our body. You already learned what is hypersensitivity and what is the example of these things. This chapter is for oral purpose and for short note also. So the long question will not come here. You have to understand what is immunity, all the disease explained by immunologically, and away from this immunity how it is happened. So today we will go for away from this immune mechanism and what is the effect of that. This, right? So this is the normal mechanism. Everybody will know this is the APC, that is the antigen presenting cell. When a bacteria or outside antigen is come, they presented with the help of MHC to the PCR, that is the P cell receptor, and this activated T cells then in turn activate the BCL for their cytokines and for clonal memory of B cells and this plasma cell for secretion of the antibody. This is the normal phenomenon for protection of our body. Now what happened? This is the antigen. When it is come from outside of our body, the antibody they will produce, they react with this antigen and antibody, they remove this pathogen outside, and this antibody is present in our body for our future protection. This is the normal homeostasis of our body. This antigen antibody reaction due to reaction from the outside pathogen. But what happens if this immune mechanism is react with this autoantigen? That antigen is coming from outside, but here the antigen is already present in our body. That is called the self-antigen. So if that antibody they produce against this self-antigen, the body will try to remove these things, the self-antigen, and they will try to discriminate between the self-antigen and non-self-antigen. If not tolerated or if not removed, there is the antigen-antibody reaction and tissue destruction, and that is today's chapter is called autoimmunity. Clear? So that is the discrimination between the self-antigen and non-self-antigen. When this immunotolerance, that is the removal of these things of value, give rise to tissue antigen as called this autoimmunity. So this is the antigen already present, that is the self-antigen. The antibody they react with these things, and this give rise to tissue destruction and autoimmune disease. So what is autoimmunity? This is the thing, that is the autoimmunity is the condition in which the body's own immunoregulatory component cells or antibody, they are failure, that is the act on the self-antigen and the antigen resulting a tissue destruction, and this mechanism is called autoimmunity. So the reaction in the autoantigen, this is the disease they produce called autoimmune disorder. So normally what happens? The immune system does not, normally the immune system does not react with the self-antigen. So they have that try to discriminate between the self-antigen and non-self. When this immune mechanism undergo breakdown, the disease they produce called autoimmune disorder. So any breach in the tolerance mechanism predisposes to the several autoimmune disease. Due to this breakdown, different types of site, that is the antigen, autoantigen present, they produce different types of material, produce a disease. This is the autoimmunity. So what we have to know? What is autoimmunity? How the immunological tolerance, so that is the discriminate between the self-antigen and that non-self-antigen is maintained in the normal health. When this breakdown, how the disease is produced, that is again self-antigen and produce the conditions called autoimmunity, and what are the factors that causes the failure of this tolerance in normal situation. There's things we have to understand. So our motto is this: immunity, what is the thing, how it acts normally, and how this breakdown of these things in the self-antigen, and what are the factors responsible for this production of this disease. Clear? Now, the normal immune system is an inbuilt phenomena where the body they try to discriminate between these self-antigen, that and the non-self antigen and the foreign body. These the withstand or the phenomena in the normally, this is called immunotolerance. And how it is occurs? Mediated by two mechanisms. That is one central tolerance and in the peripheral tolerance. Central tolerance means when the developing cells, that is the immunocompetent cells are the T cell, B cells. T cell after development, they go to the thymus and the bone marrow and lymph node, the B cell. So for their CD marker, and for maturity, they will come from the thymus for T cell in the periphery. B cells on the same thing, from the bone marrow and the lymph node will come outside for this thing. So any tolerance, if it is breakdown, give rise to the reaction to the self antigen and that disease is the product. So we have to understand this thing. So it is the autoimmunity is this thing. That is the failure of distinction between the self antigen and non-self antigen. Instead, the body reacts immunologically for tissue destruction and autoimmune disorder. Now, what is the thing? So, immune deficiency, that's discriminate between the self antigen, and this is the method how they tolerate by deletion. That is the active T cells or active B cells undergo clonal deletion. That is the reactive cells. Normally, they will not react. If during development any reactive cells they produce during their process, they will eliminate by deletion or apoptosis or by other clonal energy. These are the methods they will eliminate from the system. Maybe in the centrally, that is a deletion, or maybe functional inactivation. That if they produce, they have to resist functionally. So they will not act on the self antigen. So this is the method normally for our normal health being. So this is the either deletion or by functional inactivation during their process of development for the receptor analysis normally. When they come out from the central to the peripheral for their function. So what is the self-tolerance? So that is the tolerance, the self-antigen between discriminant between the self and non-self. This is called the tolerance. That is the withstand of this antigen. How they occurs? By central tolerance in the thymus and bone marrow during development. When they come out from the development, after development in the periphery, how they are removed from that body. So it is our protective mechanism in our body to maintain a without disease and normal health being. So central tolerance means the central tolerance by clonal deletion, that is in the thymus, in maybe in the bone marrow, they have normal receptor or maybe a highly reactive to self antigen receptor. If the body it's seen that is the receptor they produce, they are not normal, they are autoreactive to that cell antigen, they either deleted or undergo apoptosis or by energy, whatever may be, they are removed from the system. This is central deletion. What about the peripheral? This is central. So this is the thymus, maybe the lymphocyte, maybe the pre-lymphocyte, they are go for maturation or they come out with the receptor for different independent of function. When it is an abnormal reactive receptor for that against the self antigen, they are central tolerance give rise to a deletion or apoptosis. So remove, they will not react normally. So the patient will, the normal healthy being will run normally. So T cell, when it come out from that development, if it is reactive, normal response, they are activated. It has two different types of T cell function. But if there is some discrepancy between that self antigen, they undergo, that is the energy when they are activated. If there is apoptotic cell, if not completely removed, they undergo deletion. Or if they produce with this active, they undergo blockage, their action, that is suppression. So these are the different methods. If they come out from the development pathway to in the periphery, they are removed either by suppression or by energy or by blocking of their function. So they will not react normally. So this is the one way. So B cell in the peripheral after the bone marrow or that lymph node, they come out. Same thing, they are receptor. When the foreign antigen or cell antigen come, they undergo apoptosis or energy. So anyway, any cell-reacted antigen, they come out with that reactive receptor, they will remove from the body and that disease will not produce. This is the mechanism. So in the short, so in the thymus, centrally in the bone marrow, in the B cell for the T cell, and the periphery they are removed, they will not react. So this is the in short. Now, what is that tolerance? How they withstand normally in the human being? They will not react. We have cell antigen in the whole body, still they are not react in our body. So this is the called tolerance. So how they occur? By the recognition of that antigen and selective unresponsiveness of that autoantigen. So how this occur? It is by sequestration of the self-antigen. We have antigen, but they are not react. How they not react? These are the sequestration of the self-antigen, generation and maintenance of the cell antigen, and the immunologically control mechanism will alter. So they will not react. So this is the tolerance. So how the sequestration of the antigen will not react normally. How? The sum of the antigen present in the deep location, they will not come in the circulation. So they will not exposed by the immunocompetent cells for their reaction. So that is the immune ignorance. That is the self antigen, when they are sequestrated in the deep seated area, they will not react because of that deep seated area not come in the circulation, in the blood circulation or lymphatic circulation, they will not react. That is the immunoignorance. And if these, some of the cytokines, they are produced, they suppress the activated cells, maybe T cells, maybe B cells, so they will ignorance, that is the immunoignorance. What is the example of some sequestrated antigen? You know, the myelin basic protein associated with the multiple sclerosis. Some sperm-associated antigen that produce in the injury to the vasectomy during sperm genesis. Lens and the corneal protein, sometimes they are infection or trauma, they will come out. I'll give the example, if it is injury to the eye, that antigen present within that injured eye that come out in the regional lymph node produce the antibody. That antibody when come in the circulation, they will react in the opposite eye of that antigen. So this is called sympathetic ophthalmia. So any infection to the one eye, sympathetically opposite eye is affected due to the molecular mimicry, due to the secretion of the antigen, due to injury they come out. So it is called sympathetic ophthalmia. If you go to the eye department, you will very often you will see this is the one infection of one eye produce another infection of the another eye produce called the sympathetic ophthalmia. And the heart muscle antigen, injury, myocardial infarction, they will antigen, they will sequestrate it and give rise to injury to the heart muscle. So these are the sequestration of the antigen. When they come out in the circulation, they are give rise to reaction and the antigen autoimmunity. See this thing. This is the one eye infection. This antigen come out from that infected eye, go to the regional lymph node, the antibody they produce, they oppositely act on the another eye, produce the sympathetic ophthalmia. Clear? So this is the another, the sequestration of the self antigen, they will not react. If they come out, they produce the reactive sympathetic ophthalmia. Generation and maintenance of the self tolerance. Already we know, any reactive receptor antibody they produce, they are removed from the body, that is tolerated by deletion and functional unresponsive inactivation give rise to the infection. Altered immunoregulatory control, we know the T cells when are activated, they are suppressed by some cytokines. The activated T cells are also suppressed their function by the different kinds of cytokines they are mediated. Now, what is the proposed mechanism of autoimmune disorder? Proposed mechanism is, these are the endogenous abnormality. There may be a genetically abnormality susceptible also triggering from the exogenous agent. What is this thing? Endogenous abnormality means altered antigen presentation, increased B cell T cell activation, defective clearance of that apoptotic cell, and release of sequestrated antigen. When they are altered, they come out, they give rise to the endogenous abnormality, give rise to immune abnormality and thus opportunity. Some genetically sequestrated host, that is the HLA gene, some of the diseases are responsible for the HLA related disease. As for example, ankylosing spondylitis, they are responsible for HLA B27. So there are some disease, they are related to genetically abnormality and the disease associated with the autoimmunity. Some of these things are triggering for the exogenous agent. You will come some of the bacterial infection, viral infection, due to their molecular mimicry. The bacteria or virus, they have molecular sequences of that amino acid. They have same sequences in the body. So when the antigen, due to the infection they produce, they will react on that with that antigen, and that is the molecular mimicry. Their disease is produced. One of the most important diseases, the post-streptococcal glomerulonephritis, but rheumatic heart disease. After 6 weeks of sore throat, the kid knew it affected, and the disease is called post-streptococcal glomerulonephritis. This is the molecular mimicry and production of this disease. So these are called the autoimmune disorder. So I am not going to this thing. So this is altered antigen presentation. That is the new epitopes, the self antigen. It was not reacted by their receptor, but if the receptor is that deformed, that is some epitopes they are exposed, they will react by the antibody. Another one is the autoantigen presentation, co-stimulatory HLA or MHC. If they are activated by different way, they also give rise to antibody reaction to that self antigen and produce the disease. Increase B cell T cell stimulation, not going details. So these are the different types of B and T cell stimulation. There maybe their function, maybe they are different types of antibody production or autoimmune regulatory by the central deletion and the peripheral deletion that I told. If there is any abnormality of that immune system, they produce or react to the self antigen and production of the tissue destruction and the disease. Defective clearance, if that cell is apoptotic, if not clearly removed from the body, they are give rise to reaction. Another is that is the sequestrated antigen, that is the multiple sclerosis, sympathetic ophthalmia, trauma to the testis, that I already told. The sequestrated antigen, when they release from the circulation, they produce this thing. Genetically, I told, genetically susceptible person, HLA gene association, HLA B27 ankylosing spondylitis. These are the HLA DB1, DQB1, these are type 1 diabetes, and SLE. These are the some things, they are genetically abnormal, susceptible person, they produce the associated disease. Identical twin, they are prone to develop on both of them can prone to develop an autoimmune disorder. Another thing, the proteins in the complement pathway, if there is a genetical abnormality, they are not activated in that immune system and produce immunological intolerance and disease production. As I already told, the bacterial infection, that is the post-streptococcal glomerulonephritis, different types of viral infection, they are prone to develop these different types of antibody which reacts alternatively in the self antigen and the disease. And other factors, that is the smoking, inflammation and tissue destruction, they are factors. Now one thing, this is in normal pancreas, they are not reactive. If there is associated with this abnormality immune system, that is the insulitis of that pancreas and produce the type 1 diabetes mellitus. This is the thyroiditis, autoimmune thyroiditis, that is autoimmune disease, myositis, autoimmune hemolytic anemia, autoimmune hepatitis. So these are the some example of some autoimmune disorder due to breakdown of this clonal or peripheral energy or that defective in the tolerance. So, defective in the self-tolerance produce the different types of disease. See this thing. See, this is the human cytomegalovirus, and this is the sequence, and this is the HLA, any molecule, they are, if there is a sequence of the same sequence. So, one of the infection of this thing, they react with this. So, these are the some sequences similar to the bacteria or virus in the body antigen. So, that is the molecular mimicry. The protein sequences are the similar. See, these are the all similar thing. Infection of these bacteria or virus, they give rise to the, due to their molecular mimicry, they produce the organ infection and autoimmune disease of that thing. So, what is the mechanism? Take home message. Normal healthy state is maintained by the immunological tolerance against self-antigen by central and peripheral level. And autoimmune disorder result from this breakdown of this thing. So, this is the nutshell you have to know for short note purpose and understand what is the autoimmunity, how it is normal maintained and the disease they produce. And some example will come. So, the autoimmune disorder of two location. One is the systemic, one is the local. Systemic, this is organ specific, these are the non-organ, that is systemic. SLE, rheumatoid arthritis, systemic sclerosis, inflammatory myositis, polyarteritis rheumatoid, Sjogren's syndrome. These are the some organ non-specific. That is the disease once possessed is systemically affected. But it is the organ specific, endocrine, GIT, hematological and other things, all the are the specific location, that is the organ specific. And non-organ specific means that is the systemically affected whole body. So, in nutshell of SLE, you have to know for your syllabus. On nutshell, what is SLE? What are the things that arise in that disease process and how they identified. In nutshell only. Usually not in come in exam some oral purpose or some shortcut purpose, you have to know. So, what is this thing? Systemic means affected almost whole body. Lupus means the wolf. The name of this comes from the lupus, it is the wolf, and erythematosus is red nail. So, the face they have the configuration of the wolf-like, that is the butterfly rash in the face, that is the systemic lupus erythematosus, and the name comes from this word. So, it is, what is this thing? Usually it is more common in the urban people. Females are more affected than the male. Identity twin is the 30%. Usually occurs in the 65 or in the early age also, and fertility relatives are more common. Children also may be affected. So, what is lupus? It is a, lupus means wolf. Disease thought to be like from the skin like wolf. That's why names comes from this SLE. It is a production of this disease called several autoantibody and give rise to a two form. One is the localized form, one is systemic. One is the SLE, one is the DLE. Systemic lupus erythematosus is called SLE, and the discoid lupus erythematosus is called the cutaneous or local SLE. Systemic and not coming, it is the characterization the inflammation of the whole body. A discoid means the local skin lesion produce a butterfly rash in the face. And pathogenesis in the genetic level in this HLA system, in that antibody against these things, or it is the environmental, that is the genetically viral infection, hormone or UV light, or B cell, T cell activation and autoantibody formation. Not details, only we know what are the antibodies they are produced. So, the antibody they are produced, this is for oral purpose they will ask, the anti-nuclear antibody against DNA and RNA. Antibodies of the double-strand DNA, dsDNA, that is the double-strand DNA, anti-Smith antibody, others are anti-RNA, anti-ribosomal antibody, anti-RO antibody, anti-histone, anti-phospholipid, anti-ribosomal P antibody and neural. So, these are the different types of antibody produced due to this HLE disease. So, these are the things you have to, sometimes they ask in the oral, but you have to know that in the clinics, they will ask what are the antibody. Because of that prescription, sometimes you will see in that examination you have to do, that is the dsDNA. do dsDNA. So then and then you will see it is the autoimmune disorder, double strand DNA, they will ask for the confirmation of this autoimmune disease. And how they identify it? If we ask for this patient come with that report, the immunofluorescence test to identify the different types of antibody against different types of nuclear and the cytoplasmic antigen. These are the things. That is the dsDNA, that is the immunofluorescent pattern of that antigen antibody. How they produce, that is the immunofluorescent test, that is the homogeneous pattern or diffuse pattern, maybe the peripheral rim, maybe the speckles pattern, maybe the nuclear pattern. Why you know? The patient will come with a report with this immunofluorescence, the photograph. So after seeing those photographs, what are the antibodies they are presenting, easily you can identify after seeing this plate. So this is the thing, the pattern of this immunofluorescence, this is the peripheral. So the antibody, they are deposited in the periphery. This is the freckle, this is the different types of spots. This is the diffuse, means the whole things are diffuse, that area. Diffuse, one is the nucleoli, that is the nucleoli of the nucleus, they are give rise to the immunofluorescence staining. So these are the different patterns of immunofluorescence due to this diagnosis. See, one is this thing. So peripheral rimming, that is the anti-DNA in SLE. Homogeneous, that is the whole is the continuous, that the anti-DNA, anti-histone. So different types of antibody, they are pattern of the immunofluorescence test will give to the disease pattern. So different, the SLE, different types of pattern give rise to the different types of antibody they are presenting thing. So one thing is, before this pattern of immunofluorescence, the pathologists how to do, they will early cell preparation, by early cell phenomena they will identify, because the antibody they are producing that system in the blood, that pathologists in the laboratory, they are identified this specific cell, this is called early cell phenomena. How that is? So this is the antibody, they form in the body and they are engulfed by these polymorphs. So this is the thing, the polymorphs they engulf, and if we see this early cell preparation, easily you can see under microscope. Before the immunofluorescence test or the molecular analysis, before that, they are identified this SLE like this way. Identification of early cell from the buffy coat or by preparation of this thing, they will do. Before the immunofluorescence test or other molecular analysis. Before that is called early cell preparation. So autoimmune disorder in the SLE, you can identify before the molecular analysis. So this is the thing, clinical presentation, butterfly rash, fatigue, maybe fever, maybe loss of appetite, weight loss, mouth ulcer. These are the some systemic character. Other so many things are there, different organs they have affected SLE, as it is a systemic disorder. We are not going, no need to think all to remember for your exam purpose only, you know some constitutional symptoms affecting the whole body. That is the clinical feature. So, nutshell, brain, psychosis, seizure, in the face, erythema, butterfly rash, heart, pericarditis, endocarditis, angina, spleen also affected, blood vessel vascularity, kidney is important for lupus, lupus nephritis, nephrotic syndrome, that is the important thing, and the whole body is affected by this. No need to all those, only you know that is a systemic affection of that disease. So, the diagnosis other than these things, the other function you have to know, these are the liver function test, kidney function test, hematological, as this is a systemic disease, all the things, antibody test, presence of antibody against nuclear, cytoplasm, blood element and anti-nuclear antibody, that is the ANAs, that physician will write, do for anti-nuclear antibody test, that is dsDNA, histone, anti-histone protein to RNA, nuclear antigen, antiphospholipid antigen, these are the antibody they produce these diseases. Only nutshell for remember the disease, the example of autoimmunity you have to know for oral purpose. So, lupus nephritis is important because they are whole kidney may be affected, class 1 to class 4, very difficult to remember for those things. when you go in the medicine department, you have to know only the name, the remember, that is the minimal mesangial lupus nephritis, mesangial proliferative lupus nephritis, focal diffuse lupus nephritis, membranous nephritis, or the advanced case. So you have to know this thing because the kidney is affected. That is the important thing. That is the SLE in kidney manifestation is very important for identification of these diseases. Now, other things are blood vessels also give rise to fibrinoid necrosis, cutaneous butterfly rash, and the heart give rise to valvular heart disease. So these are the some skin. See this, the butterfly rash. Skin is affected. Whole skin they are give rise to lupus systemic lupus erythematosus. So what is the summary of this today's class? You have to know the immunity. What is this thing? How normally it is not affected in the self-antigen and non-self-antigen. When there is a breakdown of this, give rise to a disease process and destruction of the tissue, produce autoimmune disorder. And another thing, how the self-tolerance, why not is affected normally, that is the self-tolerance. That is the deletion and the peripheral tolerance in the centrally and peripherally. And when these mechanisms undergo breakdown, due to the several mechanism, endogenous mechanism, maybe genetic mechanism, by triggering some endogenous or exogenous agent, we produce this disease. So this is the nutshell of autoimmunity. Only the oral purpose and short note purpose is know this thing. Okay? Now anything, any question, any clarification, it's ready. So immunity, normal immunity, you know that thing. Hypersensitivity, the 4 hypersensitivity for short note. Any short note in your full semester question, any one of the short note, type 1, type 2, type 3, particularly type 4. And the how you draw under microscope the type 4 hypersensitivity, that is the tubercular granuloma. And the short note. Autoimmunity, how we are understanding normal mechanism and abnormal mechanism in the immunotolerance, how the breakdown of immunotolerance and the disease, some example, and nutshell of SLE for example. Usually not come in the exam, for understanding an oral purpose, they will ask. Okay, any question you ask.
Good morning. So today we will discuss a very important chapter about the antidepressant drug, depression. So what do you mean by depression? So depression is basically a disease. It is not a symptom. There are various types of the symptoms that can, in constellation, can be defined as depression. For example, there is low mood, irritability, anhedonia. Anhedonia means loss of pleasure in anything. If that is present for more than 3 months or 4 months and most days of a week, then it can be called a depression. Now what happens, there are different types of the drugs that can be defined as antidepressant drugs, and these are used not only for the treatment of the depression but also different other neurological conditions. So antidepressant drugs are not only for only depression. There are very common diseases or symptoms for which we have to use the antidepressant drug. For example, one thing is the neuropathic pain. In diabetes mellitus, for example, you will know later that neuropathy, chronic neuropathy or neuropathic pain is one of the most troublesome problems of the diabetes mellitus. Neuropathic pain due to other diseases that can be cured by that can be controlled by the antidepressant drugs. There are many other diseases. For example, there may be obsessive compulsive disorder. There may be generalized anxiety disorder. There may be some post-menoregic depression or postpartum depression. All these can be treated by the antidepressant drugs. So what happens? Antidepressant means these are used mainly to replenish the neurotransmitters in the neurotransmitter junction. In depression, there are mainly depletion of the neurotransmitters, most commonly the norepinephrine and serotonin. And you have already read about how the cholinergic and noradrenergic systems operate in the ANS chapter. So there are neurotransmitters, and these neurotransmitters ultimately act on the post receptor different factors, post neuron receptors, and ultimately transcription factors give rise to different types of the effects. In depression or in related disorder, there are depletion of these neurotransmitters in the neurotransmitter junction. So we have to give some drugs that ultimately leads to more availability of this neurotransmitter in the neuromuscular junction. So these are the effects by which the antidepressant drugs act. Now antidepressant drugs can, in nutshell, can be divided into some parts. The most first antidepressant drugs that came is the monoamine oxidase inhibitor or MAO inhibitor. MAO inhibitor is the first drug that can be used as antidepressant drugs, but there are different types of the drug and food interactions. For example, tyramine containing drugs, if it is given with the MAO inhibitors, monoamine oxidase inhibitors, that can lead to very high blood pressure. Hypertension can generate. For example, cheese reaction. So tyramine is present in the cheese. So cheese, if it is taken with some non-selective MAO inhibitors, that can also lead to palpitation, flushing, sudden rise of the blood pressure. This is known as the cheese reaction. So these are the problems of the MAO inhibitor, most commonly the non-selective MAO inhibitors. So there are now some selective MAO inhibitors have come. The most common name is the moclobemide. Moclobemide is the reversible inhibitor of the MAO-A inhibitor. So monoamine oxidase, monoamine oxidase, there are two types of the monoamine oxidase, type A and type B. Full screen করে দাও. Type A and type B, তার মধ্যে যেটা reversible inhibitor of the MAO-A তাকে বলা হয় moclobemide. So now coming to the slides, depression already I have discussed. So this is basically a disorder that affects the mood. So this is a mood disorder. So disorders of the mood rather than disturbance of the thought or cognition. Disturbance of the thought or cognition mainly occurs in the psychosis. So psychosis we will discuss in the next class about the antipsychotic drugs. So this is the depression. There are disturbance in the mood. And clinical depression is feeling sad or depressed mood for more than 2 weeks. So there are different types of the symptoms just in the nutshell. So there may be some emotional symptoms already I have discussed, like intense feeling of sadness, hopelessness, despair, anhedonia, feeling of guilt, ugliness, loss of motivation, energy and interest. There may be retardation of the thoughts and actions, loss of libido, loss of appetite and sleep disturbance. Sleep disturbance means both insomnia or hypersomnia can occur. So in some patients there may be less sleep, in some patients there may be more sleep. Similarly, for food also, for some patients the patient will not eat and some patients will take more foods. So these are the different types of the symptoms that can happen. So in the opposite spectrum of the depression there is mania. So if we can consider that this is a depression, this is a spectrum of mood. So in the one there is mania, in the other there is depression, and in the middle there are different types of the conglomeration of the symptoms. So mania is basically euphoria, happy, excited, euphoric, self-confidence, lack of judgment, sudden odd decisions, excessive rapid talking, moving quickly from one to another. This is known as the flight of ideas. Hyperactive and full of energy, unable and unwilling to sleep. So there is sleep deprivation in those patients. Sudden irritability, rage, impatience, aggression, all can happen. So mania is also a disease that can also be treated by different types of the drugs like this. So classification of depression: mild, moderate and severe according to the symptoms and according to the duration. And there may be unipolar depression or bipolar depression. Unipolar means only towards the depression it is tilted. Bipolar means there may be alternatively mania and depression. Both can happen as a cycle. For some months it is mania, for some months it is depression. So bipolar disorder is another disease that can be treated by different types of the mood stabilizers in addition to antipsychotics or antidepressants will come. So bipolar depression, in which depression alternates with mania. So there may be other forms. So depression is not a sacrosanct entity that may be associated with psychosis. So there may be psychotic depression, postpartum depression, what I am talking, this is very common. So after birth of the babies, there may be postpartum depression in approximately 20 to 30% of the ladies. There may be atypical depression, that is depression is present but the symptoms are not at all, that is commonly seen. So possible mechanisms, the mechanisms already I have discussed. So there is insufficient central release of the norepinephrine, noradrenaline and 5-hydroxytryptamine, that is the serotonin. So in the neuromuscular junction, there is deficiency of neurotransmitters, most commonly the norepinephrine and serotonin. There are numerous other hypotheses also. This is known as the monoamine hypothesis. Okay. So the monoamine theory of the depression, on the basis of which most drugs are usually operate. So monoamines, so these are the monoamines, the noradrenaline, serotonin, these are the monoamines. So there are depression is caused by a functional deficit of monoamine transmitter at certain sites in the brain, like deficit in amount or function of cortical and limbic serotonin, norepinephrine and in some cases also dopamine. While the mania is the other part of the extreme where these neurotransmitters are seen to found having functional excess. So remember how the depression happens according to the monoamine hypothesis. There are deficiency, both there may be functional deficiency or there may be actual deficiency. Functional means it is present in the neuromuscular junction, the neurotransmitters are present, but all of the neurotransmitter cannot act on their receptors because some of it can be taken back, or there may be some problem in the receptor. So this is the functional deficit. So functional deficiency, whatever may be, the deficiency of the monoamines. Monoamines means most commonly the norepinephrine and serotonin, in some cases dopamine. So this deficiency is present in the neurotransmitter junction. And this theory is basically proposed first in the 1965 based on the ability of the known, we have seen that most of the antidepressant drugs basically increase these monoamines in the certain parts of the brain like the cortical and limbic areas. These cortical and limbic areas mainly control this mood stabilization. So you can see this is the nerve, what we have already seen in the NS. So when there is action potential, there is release of the neurotransmitter from the presynaptic vesicles. So presynaptic vesicles contain either norepinephrine or serotonin or dopamine that is released when the action potentials came, and so this neurotransmitter act on their receptors in the postsynaptic junction, and some part of this neurotransmitter are taken back to the presynaptic part, and some part of it is metabolized. The metabolism is done most commonly by this monoamine oxidase. Okay. So ultimately the net amount of the neurotransmitter that is present in the neuromuscular junction acts on the receptor. So if there is deficiency, so normal synapse, when there is normal synapse, these red ones are the neurotransmitter, monoamine neurotransmitter, there is no depression, all of this can act on their receptors. But when there is deficiency, you can see these red ones are very less. So there is less neurotransmitter in the neuromuscular junction, there may be myriad reasons, and ultimately there is less binding of this neurotransmitter on the postsynaptic receptors. So that leads to depression. So there may be deficiency of the serotonin that may cause the sleep problems, irritability and anxiety that is associated with depression, and there is decreased level of the norepinephrine which regulates the mood, alertness, arousal, appetite, reward and drives, and may contribute to the fatigue and depressed mood of the illness. And dopamine is important for pleasure, sexual and psychomotor ability. In some of the cases there are dopamine deficiency also. And this monoamine hypothesis is not only the one hypothesis, associated with this some other problems also happen in the depression, like neurotropic hypothesis, where the brain derived neurotropic factor which is critical in regulation of the neural plasticity, resilience and neurogenesis, that is also becomes very less. So there are loss of neurotropic support to the brain, most commonly in the cortical and limbic areas of the brain. So this is the neurotropic hypothesis. So treatment of the depression, how we will treat the depression? Psychological treatment usually done by means different types of the counseling, and there are different processes of the counseling are there. And the most important part is the pharmacological treatment, what we have started discussing. 70% of the depressed patients respond to antidepressants, and some of them becomes refractory depression, which are not responding to different types of the antidepressant drugs. in which the electroconvulsive therapy, electric shock যেটাকে বলি আমরা, সেক্ষেত্রে দেয়া হয়। So pharmacotherapy, antidepressants যেটা আমি স্টার্ট করেছিলাম, সো অ্যান্টিডিপ্রেসেন্টস কিন্তু কাজ করতে অনেকটা সময় লাগে। ইট ইউজুয়ালি টেক্স minimum 2 weeks to 2 months for the first manifestation of the good effects for the depression. So if we are starting with one antidepressant drugs, we have to wait approximately 2 to 3 months to see whether this antidepressant drug is taking its effect or not. If it is not taking its effect, we can add another antidepressant drugs, or we can change the antidepressant drugs. And if the depression is associated with other problems, like there may be some mild portions of the psychosis, there may be OCD, or there may be some other symptoms, we have to add the other drugs as well. So the most consistent adaptive change seen with antidepressant drug is the down regulation of the beta, alpha 2 and 5-HT2 receptor. Alpha 1 is not affected. So when we are giving the antidepressant drugs continuously, these antidepressant drugs not only act only on the norepinephrine or serotonin receptors, they have other effects on other receptors also. So there may be some down regulation and up regulation of different other receptors. This is important because the adverse effects mainly generate due to these antidepressant drugs, because they are acting not only those receptors that are related to depression, but also other receptors also. For example, they also act, some of them can also act on the alpha receptors, some of them act on the beta receptors, some of them act on the histamine receptors, like that. So this is the basis of the side effects. They affect only people who are depressed. So for normal people, if we are giving the antidepressant drugs, there will be no effect in most of the cases. Effect does not increase with increasing doses. In most of the cases, we have to change the drug if it is not responding. Antidepressants are not habit forming. So this is the difference with the benzodiazepines. So you will read the benzodiazepines, different types of the benzodiazepines that most commonly use the sedative hypnotic. যেমন clonazepam, lorazepam খুব commonly used হয়, alprazolam তো প্রচন্ড habit forming, but antidepressant drugs are not habit forming. So we can discontinue the antidepressant drugs as we need. But in most cases of the benzodiazepines, the patient cannot get sleep or cannot get her symptoms abated if the benzodiazepines are discontinued. So this is known as the habit forming drugs. Antidepressant drugs are not habit forming, but the benzodiazepines are the habit forming drugs. Antidepressants differ widely in side effects because of their effect on other receptors. Hence the side effect varies. So we have started with the monoamine oxidase inhibitors. So this is the first group of the drugs that was discovered for the treatment of the depression or related disorder. What I am talking about, there are problems with the interactions. So these are the tranylcypromine and phenelzine. These are the different types of the MAO inhibitors that are lesser used now, and the moclobemide, the reversible inhibitor of the MAO-A, that is the newer ones, lesser side effects. Tricyclic antidepressant and tetracyclic antidepressants is the next group of drugs that was discovered and very indiscriminately used. There are different other drugs like imipramine, clomipramine, doxepin, amitriptyline, trimipramine, desipramine, nortriptyline. Of this, you can see this amitriptyline, nortriptyline, imipramine, clomipramine, these are very commonly used even nowadays in different types of the other diseases. Not only depression, but different other diseases we will discuss. So tricyclic antidepressants, there are some newer generations of this antidepressant. There are tricyclic mean there are 3 cycles. There may be some 4 carbon rings also. This is known as the tetracyclics. Example are amoxapine and meprotylene. So these are the tetracyclic antidepressants. So there are 2 groups, these 2 groups, and then the third group is the selective serotonin reuptake inhibitor. This is the next group, and right now this is the most commonly used and the first line of the drug for the treatment of the depression and many other diseases. So SSRI is usually the first line of drug because of their lesser side effects. Tricyclic antidepressants or monoamine inhibitors are second or third line of the drugs. Okay, so examples are the fluoxetine, sertraline, fluvoxamine, paroxetine, citalopram, escitalopram. All of these are very commonly used. Okay, of this you can see the escitalopram is the most commonly used, and then fluoxetine and sertraline. So these are the selective serotonin reuptake inhibitors, in short SSRI. There are different other drugs that act specifically on different receptors, so we can divide accordingly. For example, there are SNRI or serotonin and norepinephrine reuptake inhibitor. Example is venlafaxine and duloxetine. This venlafaxine and duloxetine also used in numerous cases. There may be some serotonin 2 antagonists and reuptake inhibitors also known as SARI. Example is nefazodone and trazodone, lesser used. There may be norepinephrine and dopamine reuptake inhibitor or NDRI. Most common example is bupropion. Bupropion is used in some specific cases. We will discuss. There may be some noradrenergic and specific serotonergic antidepressant or NASSA. Example is mirtazapine. Noradrenaline reuptake inhibitor is the reboxetine and serotonin reuptake enhancer is the tianeptine. All these basically falls under some atypical antidepressant drugs. Okay. So atypical antidepressants, if we are asked, these are the other drugs apart from tricyclic antidepressant, SSRI, SNRI and the MAO inhibitors. So there may be trazodone, mianserin, mirtazapine, bupropion, tianeptine, amineptine, atomoxetine. So these are the different ways by which we can classify the antidepressant drug. So in commonly we can classify typical, atypical, or according to the different receptors or the reuptake inhibitors, accordingly we can classify. Okay. So these are the atypical antidepressant drugs. So first coming to the tricyclic antidepressant drugs. These are the one of the oldest of the antidepressant drugs. You can see there are 3 cycles, 3 ring, carbon ring, that's why tricyclic. The first tricyclic antidepressant discovered was the imipramine, still now used in different other different cases. Already we have seen about the examples. Very important, you have to learn about the examples of the tricyclic antidepressant. Mechanism of actions, similarly, already we have discussed. All these tricyclic antidepressants, basically they are blocking the reuptake pumps. So some part of these neurotransmitters are reuptake back to the presynaptic neurons. So if we are blocking the reuptake pump, so there will be more availability of these monoamines in the neurotransmitter junction, so that more neurotransmitter can act on their receptors. Simple thing. So for serotonin and norepinephrine in nerve terminals, by competing for the binding site of the transport protein. So ultimately there are increased concentration of the norepinephrine and serotonin in the synaptic cleft and at the receptor site, facilitation of the norepinephrine and serotonin transmission, so improve symptoms of the depression. Some have more potency for inhibition of the serotonin, some have more potency for inhibition of the norepinephrine. So different drugs differ according to their specificity and their potency for different types of the receptors. These are the example: clomipramine, imipramine, amitriptyline. Example is nortriptyline, desipramine, etc. So the same thing you can see. This is the release of the neurotransmitter and some part of it is reuptake back. This reuptake is blocked by the tricyclic antidepressants. So apart from this, they are also blocking different other receptors. What I am talking? So they are also blocking different other serotonergic receptors, alpha adrenergic receptor, histaminic receptor, muscarinic receptors, etc., etc. This ultimately leads to different types of the adverse effects. So what are the pharmacological actions? When the tricyclic antidepressant is given, they elevate mood, improves the mental alertness, increase physical activity, and in non-depressed patient, usually they cause some part of the sedation, confusion and motor incoordination. Usually this occurs due to their action on other receptors. For example, they are blocking the histamine receptor. So ultimately there will be drowsiness like this. The reuptake block occurs quickly, but the antidepressant effect develops after weeks. So usually immediately there is blocking by antidepressant effect for all of the antidepressant drugs usually takes time because there may be some neuromodulation and synaptic changes, and this usually takes time. This is known as the time dependent changes that culminate in the antidepressant effect. And there are certain adaptive changes also. Initially the presynaptic alpha 2 and 5-HT1 receptors are activated. Later they are desensitized or downregulated, these receptors. Net effect is the enhanced norepinephrine and serotonin transmission. These are the different adaptive changes. When we are giving these drugs, firstly there is blockade, and when this drug is continuing for weeks or months, there are adaptive changes in the receptors, and ultimately the net amount of the neurotransmitters increases in the synaptic cleft. Peak levels usually 2 to 6 hours post ingestion, Most of these are lipophilic in nature, that is lipid soluble. Therefore, they are well absorbed from the gastrointestinal tract and readily cross the blood-brain barrier to penetrate the CNS. Elimination mostly by the hepatic oxidation. They are metabolized in the liver by different types of the metabolism. For example, imipramine to desipramine, amitriptyline to nortriptyline. So these are the active drugs, products and active drugs. Both of these can be used as a drug. They are strongly bound to plasma proteins. Average half-life is approximately 24 hours and in overdose approximately 72 hours. That's why in most of the cases, this can be given as once daily dosing. Large T-half and large volume of distribution. So, and they have narrow therapeutic index. So, this is important for the poisoning. Because these patients are depressed, because these patients are taking the tricyclic antidepressant for the longer period of the time. So, there is always chance, and in the whole of the world, tricyclic antidepressant poisoning is very common. And tricyclic antidepressant poisoning can happen when it is taken large amount of the TCS. So, TCS block this alpha 1, H1, M1 and 5-HT2 receptors. So, you can see these receptors are blocked and this leads to different side effects of the tricyclic antidepressants. So, what are the side effects? Anticholinergic, because they are blocking this receptor. So, there may be dry mouth, bad taste, constipation, epigastric distress, urinary retention, blood vision, palpitation, all this can happen. So, one is anticholinergic side effect. Next is sedation, mental confusion, weakness. This can happen more with some drugs like amitriptyline and some sedative congeners. Increased appetite and weight gain are very common, most commonly with the sertraline. Some patients receiving any antidepressant may abruptly switch over to a dysphoric aging. There may be some spectrum changes from depression to mania can happen. So basically these are the cases of the bipolar depression cases which are unflourished. When we are giving the antidepressant drug, the spectrum have been tilted towards the other extreme, that is the mania. Sweating, fine tremors can happen. Seizure threshold is lower. That means there may be always chance of the epilepsy, seizure. Postural hypotension can happen, especially in older patients. So we have to be cautious about the elderly patients when we are prescribing this. It is less severe with the desipramine. So desipramine should be given in the elderly patients because there are less postural hypotension. Means that if the patient just sits from the supine position, there may be some decrease in the blood pressure and there may be vertigo. Sexual distress can happen, especially delay or interference with erection, ejaculation and occasionally with orgasm. This is very common with antidepressant drugs, some sexual problems. Cardiac arrhythmia may happen in patients with ischemic heart disease because many of these patients are elderly patients. So, there may be some problems with the ischemia in the heart. Arrhythmia may be responsible for sudden death in some patients. Amitriptyline and dorsolapen are particularly dangerous in overdose. So, this amitriptyline overdose is very common in our country also. Higher incidence of the arrhythmia is usually caused due to this overdoses. So, what I am talking about the acute poisoning of the tricyclic antidepressants. When there are acute poisoning, there will be depressed respiration, there are delirium, anticholinergic symptoms, there are muscle spasm, convulsion, coma and ultimately death can happen if the treatment is not initiated within a few hours. Mainly, firstly, support have to be given according to the gastric lavage, respiratory assistance, fluid infusion, maintenance of the blood pressure and body temperature. And remember, the main drug that is used for the tricyclic antidepressant poisoning is the bicarbonate. So, IV sodium bicarbonate is usually given mainly to change the acidosis and it also acts to decrease the side effects from the tricyclic antidepressant poisoning. And after the patient is supported, then for diazepam can be given for convulsion or delirium or other drugs can be given like to treat the cardiac arrhythmia, propranolol or lidocaine can be given. So remember, for tricyclic antidepressant, the first line of the drug is the IV sodium bicarbonate. Okay. And there may be interactions with the other drugs also. They are strongly bound to plasma protein. That's why there are some other drugs that can replace these drugs from their plasma protein binding site that can lead to toxicity of the drug also. They are metabolized by the liver microsomal enzymes. Again, other drugs that can inhibit or induce these liver microsomal enzymes, there may be problems of the metabolism of these drugs. So if they are given with this MAO inhibitor already I am talking, if they are given with some tyramine containing food or this tricyclic antidepressant, there may be sudden rise of the blood pressure. This is known as the hypertensive crisis. So hypertensive crisis can happen. So you can see the tricyclic antidepressant drug. So mutual enhancement of their effects can happen when we are using some other monoamine oxidase inhibitor. You can see there is enhancement of their effect. So there may be hypertension, hypertensive crisis, hyperpyrexia, very high temperature of the body, convulsion and coma can happen. If we are using some other directly acting adrenergic drugs with this tricyclic antidepressant, they also potentiate these effects and there may be different types of the adverse effects. On the other hand, if the ethanol or other CNS depressants are used, that also leads to toxic sedation. So sedation will be toxic. Again, the patient can go to the coma. And again, if we are using high dose of the indirectly acting adrenergic drugs, that also leads to toxicity. So the other drugs have to be given cautiously when we are using the tricyclic antidepressant drugs. So amoxapine is another drug. This is basically some modification with the tricyclic antidepressant. That's why this is a tetracyclic compound, and it also blocks the dopamine receptors in addition to their norepinephrine receptor blockade. So there are some additional action of the dopamine blockade. Otherwise, more or less similar mixed antidepressant and neuroleptic properties are there. Risk of extrapyramidal side effect is also there. When we read about the antipsychotic drug, we will see that the extrapyramidal side effect is most common side effect of the typical antipsychotic drug. Since they have some neuroleptic property like antipsychotic property, they have also an extrapyramidal side effects. Details is not required, just remember the name and about their dopamine blocking action. So contraindication, this tricyclic antidepressants should not be used in patients with glaucoma and with enlarged prostate, because there may be some urinary retention. More urinary retention, there may be anuria. Urine cannot come at all. This can happen due to their atropine-like action. These are contraindicated in manic depressive illness, that is bipolar illness. When there is bipolar illness, we are treating the depression, the patient ultimately leads to manic episodes. So that's the problem. Here for the bipolar disorder, we have to use the lithium salts. We will discuss in the next class. Next, the monoamine oxidase inhibitor. We have started with the monoamine oxidase inhibitor. These are the monoamine oxidase inhibitor: phenelgine, phenylcypromine, isocarboxazide, moclobemide and pargylene. Onset of antidepressant action similar, minimum 2 to 4 weeks is there. This is found in nearly all tissues located intracellularly associated with mitochondria. Mitochondria মধ্যে থাকে. Present in nerve terminals that release norepinephrine, dopamine or 5-hydroxytryptamine, located on outer surface of the mitochondrial membrane. So cell যে mitochondria থাকে তার outer surface এ এই monoamine oxidase গুলো থাকে. In neurons, this monoamine oxidase oxidatively deaminates and inactivates any excess norepinephrine, serotonin and dopamine. মানে যখন যে monoamines গুলো আসছে synaptic cleft এ, some part of it is metabolized by this monoamine oxidase. Okay, this monoamine oxidase oxidatively deaminates and inactivates this, and some part of it is reuptake by means of the back to the presynaptic neuron. So here we are blocking the metabolism of these monoamines. So monoamine is not involved in the inactivation of the release transmitter. So already release transmitter inactivation সাধারণত হয় না, তার আগে রিলিজের আগেই ইন্ট্রাভেসিক্যালি আমরা সেটার কিছুটা মেটাবলিজম করে দিতে পারবো যদি আমরা inhibit kori monoamine oxidase ke by means of the monoamine oxidase inhibitor. So you can see this monoamine oxidase inactivates the monoamines, norepinephrine, serotonin and dopamine. These are the monoamines that leak from a synaptic vesicles. So these are the synaptic vesicles that mainly contain the monoamines that comes to the synaptic cleft. Before coming to the synaptic cleft, some part of it is metabolized. So effect of the MAO inhibitor, when we are inhibiting this, they prevent the inactivation of the monoamines within a neuron, causing excess neurotransmitters to diffuse into the synaptic space. So you can see there are more neurotransmitters are present when we are using the monoamine inhibitors. So this is the other way by which we can increase the monoamines in the synaptic cleft. So there are two types of the MAO enzymes, MAO A and MAO B. Okay. monoamine oxidase inhibitor A metabolizes norepinephrine, serotonin and tyramine, and inhibition of this MAO-A produces the antidepressant effects. And MAO-B is the specific for dopamine. Inhibition of the MAO-B produces anti-Parkinsonian effects. So when we read about the anti-Parkinsonian drugs, that is drugs from Parkinson's disease, we read about the MAO-B, selective MAO-B inhibitor. Selagilin, rasagilin, these are the selective MAO-B inhibitors which will be discussed then. Selagilin, rasagilin, not discussed here. Here mainly we need MAO-A inhibitor, selective MAO-A inhibitor. But most commonly we are having different types of the non-selective inhibitor, that is they are blocking both the MAO-A and MAO-B. So these are example of the phenelgine, prenylcypromine, isocarboxazide and pargailin. These are irreversible and non-selective MAO inhibitor, also known as the classic MAO inhibitor. They cannot distinguish between two isoenzymes. Their activity cannot be restored unless new enzyme is synthesized. Therefore, when we are giving this MAO inhibitor, for 2 to 3 weeks needed after stopping of treatment to initiate a new drug, because their effect lasts for 2 to 3 weeks. Because these MAO inhibitors, if they are inhibited, the monoamines will not be metabolized until a new enzyme is synthesized, and new enzyme synthesis usually takes 2 to 3 weeks. Okay. So reversible and selective inhibitor of the MAO-A inhibitor recently came, known as the moclobemide, which are antidepressant effect and short acting. Short acting, that's why the adverse effects are also less. And there are selective inhibitor of the MAO-B like selagilin, deprenyl, selagilin, rasagilin. You will read about the Parkinsonian chapter. Side effects, hypotension can happen. So there may be sudden hypotension, there may be antimuscarinic effects, similar anticholinergic effects. There may be CNS stimulation, there may be weight gain. All this can happen with the MAO inhibitor. And drug interactions like tricyclic antidepressant, there are many drug as well as food interactions with MAO inhibitor. Like petidine, when the petidine or morphine it is given, there may be severe hyperpyrexia, restlessness, coma, hypotension can happen. When levodopa is given, levodopa is used for the Parkinson's disease. When it is combined, there may be hypertensive crisis, what I am discussing, sudden rise of the blood pressure. Amphetamine and ephedrine, these are basically indirectly acting sympathomimetic agent. You have already read in the NS chapter, amphetamine, ephedrine. When these are used with MAO inhibitor, there may be again hypertensive crisis. There may be sudden rise of the blood pressure. When the tricyclic antidepressants are given, just now we have discussed, tricyclic antidepressant and monoamine oxidase inhibitor, both should not be given together because there may be hypertensive crisis. Again, sudden rise of the blood pressure. Again, the monoamine oxidase inhibitor and SSRI should not be given. There may be serotonin syndrome, similar to that of the hypertensive disorder. This is known as the cheese reaction, what I am talking. So tyramine is an indirectly acting sympathomimetic agent, and this is present in the cheese and cheese-like substances. So this occurs when tyramine-rich foods are taken with MAO inhibitors. So the patient is taking this MAO inhibitor, most commonly the non-selective MAO inhibitors, and the patient is taking some cheese or some foods like that contains the tyramine. This tyramine or tyramine-like foods are the indirectly acting sympathomimetic drugs. And already we have seen, if the indirectly acting sympathomimetics are given with these MAO inhibitors, that leads to sudden rise of the blood pressure or hypertensive crisis. And these tyramine-rich foods, what are the examples? Old cheese, concentrated yeast products, pickled or smoked fish, red beans, red wine, chicken liver and sausage. So if these patients are prescribed, they have to be told that you should stay away from these foods while you are on this drug. Okay, otherwise there may be problem. So this tyramine in food is normally degraded in the gut by the MAO-A inhibitor, and this tyramine from the ingested food is taken up, and ultimately this is converted to octapamine. This octapamine is a false neurotransmitter which causes massive release of the norepinephrine and may result in hypertensive crisis. Already they are increasing the norepinephrine. When these two are given, they give a synergistic effect, and there is sudden release of the more norepinephrine in the synaptic cleft that leads to sudden rise of the blood pressure, and that leads to stroke or severe also. So treatment, we have to treat this cheese reaction with the prazosin or phentolamine. So this prazosin or phentolamine are the alpha blocker drug. Already you have read in the NS chapter, alpha blocker. So the treatment of the cheese reaction is the alpha blocker, prazosin or phentolamine. At least 10 milligram tyramine needs to be ingested to produce this reaction. So very small amount will not cause this. The special advantage claimed for this moclobemide is that no cheese reaction occurs with its use. So this moclobemide is the reversible inhibitor of the MAO-A that ultimately leads to very less or no cheese reaction. So cheese reaction is very important for your exam also, Viva. So this moclobemide already we have taken. This is a reversible and selective monoamine oxidase A inhibitor. Competitive enzyme inhibition basically happens. It lacks the anticholinergic, sedative, cognitive, psychomotor and cardiovascular adverse effect. That is, different adverse effects are lesser here. Particularly good option in depression in elderly patients and in those with heart disease and social phobia. So social phobia, oneke social interaction phobia thake, sei social phobia ক্ষেত্রে elderlyদের ক্ষেত্রে বা those patients who have heart disease তার ক্ষেত্রে ডিপ্রেশন আছে, সেক্ষেত্রে আমরা মক্লোবেমাইড ইউজ করতে পারবো। Adverse effects are lesser. Therapeutic use mainly MAO inhibitors. It is basically very less used nowadays. What I am talking because of this large drug or food interactions, it can be used in some phobic disorder like social phobia, atypical depression, and in endogenous depression that is refractory to other types of the drugs. Next, coming to the SSRI, selective serotonin reuptake inhibitor. This is also very important. Fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, escitalopram. All these drugs are very commonly used. Selective serotonin. So they are currently the most widely utilized class of antidepressant drugs. They act within the brain to increase the amount of the neurotransmitter serotonin like 5-hydroxytryptamine in the synaptic gap by inhibiting its reuptake. So basically they are inhibiting the reuptake. That's why reuptake inhibitor, selective serotonin, because they are selectively inhibiting the reuptake of the serotonin and their effect on other neurotransmitters are less. Because this is less, that's why the side effects are also less in comparison to the tricyclic antidepressant or monoamine oxidase inhibitor. So they are described as selective because they affect only the reuptake pumps responsible for serotonin as opposed to earlier antidepressants like tricyclic antidepressants which can affect the other monoamines also. Okay. So you can see have delayed onset of action extending several weeks because again the plasticity, the change, neuroadaptive changes occur when we are giving the selective serotonin reuptake inhibitors for large number of days. So these are the receptors, reuptake pumps in the presynaptic neuron that are blocked. So when these are blocked, there may be autoreceptor desensitization. If it is given for long period of time, the receptor pumps are basically desensitized or down-regulated. That is, less number of these receptors are expressed. That's why more availability of this neurotransmitter in the synaptic cleft. The same thing, the down-regulation of the autoreceptor causes the neurons to release more 5-hydroxytryptamine. They have delayed onset of action, already we have seen. Again the same thing. So what are the advantages? Produce little or no sedation. So they have more selective action, that's why there are less adverse effects. Just remember this. So produce little or no sedation, do not interfere with cognitive or psychomotor function and produce anticholinergic side effects. So anticholinergic side effects like dry mouth, blood vision, these are less. They are devoid of adrenergic blocking action. That's why postural hypotension also less or does not happen. That's why it can be given in elderly patients, suitable for elderly patients. They have practically no seizure precipitating function. That's why epileptogenic potential is also less for these patients. Weight gain is lesser problem in comparison to the other drugs. In comparison to the MAO inhibitor, they do not cause this cheese reaction, already I have discussed. Acute toxicity also lesser, because large number of these pills, if it is taken, there is lesser chances of the acute toxicity. Fluoxetine is the first SSRI that was discovered. The half-life after a single dose is 2 days. That's why it is a very long-acting drug. The liver metabolizes into norfluoxetine and ultimately this is metabolized out. It also involves the P450-2D6 system. That's why there may be some drug interactions are there, and it is approved for use in children greater than 7 years and adolescents, and it is relatively safe in pregnancy. So fluoxetine can be given after 7 years and also in the pregnancy. Fluvoxamine is a shorter acting SSRI. T-half is lesser, 18 hours. This fluvoxamine now specifically recommended for generalized anxiety disorder, and fluvoxamine is most commonly now used in OCD, obsessive compulsive disorder. অনেকে হয়তো শুনেছিস বা বিভিন্ন মুভিতেও দেখেছিস অবসেসিভ কম্পালসিভ ডিসঅর্ডার, মনে কর কেউ একটা তালা লাগালো কিন্তু বারবার তালাটা চেক করেই যাচ্ছে যে তালাটা লাগানো হয়েছে কিনা, বাইরে বেরিয়েও, মানে অবসেশন কিছু একটা থাকছে, তার ফলে কম্পালশন, মানে অবসেশন যে ওটা হয়নি কোন একটা কাজ ওটা করা সত্ত্বেও, এবং তার দ্যাট লিডস টু কম্পালসিভ বিহেভিয়ার। দিস ইজ নোন অ্যাজ দ্য obsessive compulsive disorder. This is also common, and fluvoxamine is the treatment of the choice for this obsessive compulsive disorder. Paroxetine is another short acting SSRI which does not produce active metabolite. Higher incidence of the gastrointestinal side effects can also occur with this paroxetine. Sertraline is also very commonly used now. It is a selective serotonin reuptake inhibitor. It is very much efficacious in juvenile depression. বাচ্চাদের ক্ষেত্রে ডিপ্রেশনের ক্ষেত্রে very commonly used. It is recommended for anxiety and also post-traumatic stress disorder. So sertraline is also one of the drug of choice for PTSD, post-traumatic stress disorder. Okay, drug interactions may be there due to some cytochrome involvement. It appears to be a minor inhibitor of the dopamine receptor, and T-half is also longer. That's why usually it is given once daily doses. So sertraline can be used in the PTSD, post-traumatic stress disorder, and anxiety disorder and juvenile depression. Citalopram and its congener escitalopram, this is most commonly used in our country nowadays because of their lesser side effects and lesser interactions with other drugs and foods. T-half is 33 hours, again it is once daily used. Overdose is very unlikely. It is the preferred SSRI for mood disorder in premenstrual symptoms. Now premenstrual symptoms যেটা হয় mood disorder সেক্ষেত্রে ইউজ করা যায়। Escitalopram is the active enantiomer, that's why it needs a lesser dosing of the drug, and its side effects are the lesser, and safety is more or less escitalopram used in different stages of the depression. Dapaxetine is the newer ones that is mainly used for delaying the premature ejaculation. So premature ejaculation is also treated by different types of the antidepressant drugs. One of the drug is the dapaxetine, and it acts rapidly, can be taken 1 hour before sexual intercourse. So dapaxetine can be used in premature ejaculation. Side effects is not important. Adverse effect of all the SSRI, most commonly the gastrointestinal symptoms. Remember, if the patient is taking the SSRI and also the patient is taking some other drugs that leads to gastrointestinal intolerance, usually different guidelines say that we should give some prazoles like pantoprazole or omeprazole. Pantoprazole is usually preferred because there may also risks of the gastric bleeding that can happen. So gastrointestinal symptoms can happen. Changes in appetite, weight loss or gain, sleep disturbance can happen with fluvoxamine, anxiety, tremor, and in the flip side, some of these drugs also leads to some sexual dysfunction also. So some of these drugs can be used for the treatment. Again, some of these drugs, if it is used for some other purposes, that leads to problem in the sexual dysfunction. And discontinuation syndrome that lead to headache, malaise, flu-like symptom, agitation, etc. Drug interactions are lesser, but it can happen most commonly again with the MAO inhibitors. With the MAO inhibitors, it is known as the serotonin syndrome. The syndrome is more or less similar to the cheese reaction. There may be tremor, hyperthermia, cardiovascular collapse, and death. So again, this MAO inhibitor should not be given together with the SSRI. This should not be given with the tricyclic antidepressants also because there may be problem. Now coming to some other atypical antidepressant drug like norepinephrine selective reuptake inhibitor. Just remember the name reboxetine and tomoxetine. Advantage is they lack the antagonistic activity in different other receptors, that's why the side effect is less. Details is not required, just remember the name reboxetine and tomoxetine. SNRI, this is important. SNRI is the serotonin and noradrenaline reuptake inhibitor. Now in our country we have venlafaxine and duloxetine. Desvenlafaxine and also is there, but levomilnacipran is not available. Just remember duloxetine and venlafaxine falls under the group of serotonin and noradrenaline reuptake inhibitor. The previous one was the SSRI. This is known as the SNRI. Okay, they inhibit the reuptake of the both serotonin and norepinephrine, effective in treating depression where the SSRI will not act. Sometimes effective in relieving pain. Now this duloxetine is the drug of choice for the diabetic neuropathy, for example. So they are used for diabetic peripheral neuropathy, post-herpetic neuralgia. So herpes zoster is a disease that leads to severe neuropathic pain, for which we can use this drug. Fibromyalgia is an unexplained pain symptoms or chronic fatigue symptoms. So there may be pain in different joints, unexplained. There may be no pathology. This is known as the fibromyalgia. And low back pain. So basically remember, these SNRIs are the first line of drugs due to different types of the neuropathic pain. Most commonly diabetic neuropathic pain, post-herpetic neuralgia, fibromyalgia, low back pain, for which we have to use the venlafaxine, duloxetine. Apart from their antidepressant action, they have little activity on the alpha-adrenergic, muscarinic and histaminic receptor. That's why the side effects are the less. And they also precipitate discontinuation symptoms in some of the cases. So site of action for the different antidepressants already we have discussed, you already know. So there may be, this is the serotonin transporter and this is the norepinephrine transporter. This we are blocking these transporters or we are blocking the metabolism. So these are the different drugs. For example, MAO inhibitors already we have seen. MAO inhibitors are blocking the monoamine oxidase that ultimately inhibits the metabolism. There may be tricyclic antidepressant and SNRIs that blocks this norepinephrine transporter and serotonin transporter. SSRIs selectively block this serotonin transporter. Tricyclic antidepressant blocks different other transporters also. So these are the different drugs that mainly acts to increase the synaptic cleft availability of the different monoamines. So uptake inhibition also varies for the different drugs. For example, you can see fluoxetine is the selective serotonin reuptake inhibitor. They have no uptake inhibition on the norepinephrine, but the maximum uptake inhibition on the serotonin. Similarly, the SNRI, already we have discussed about the duloxetine and venlafaxine. Somewhat they are blocking this norepinephrine and also blocking the serotonin, very large. And tricyclic antidepressant is a non-specific blockers of the different receptors. So all these, and within the group also, one drug varies from the other according to their selectivity and their potency of action on different receptors. Atypical antidepressants already we have discussed. Another important drug is the bupropion. Bupropion is an antidepressant of the amino ketone group. They has excitant rather than sedative property. So when bupropion is given, they giving some excitant effect in comparison to the other ones. And bupropion is basically useful. What are the use of the bupropion? Decreasing the cravings and attenuating the withdrawal symptoms of the nicotine in patients trying to quit smoking. So smoking cessation এর ক্ষেত্রে different drugs use করা হয়, যেমন nicotine chewing gum আছে, অন্য আরো কিছু drug আছে. The most important is the bupropion. So bupropion is the antidepressant drug that is used for the smoking cessation that decrease the craving of the smoking. Side effects, there may be dry mouth, sweating, nervousness, etc. They are also metabolized by the cytochrome enzymes and they are contraindicated in bipolar disorder and seizure. So bupropion is a drug used for the smoking cessation. Remember, very important. Trazodone and the nefazodone is serotonin 2A antagonist and reuptake inhibitor. So they are blocking the receptor also, serotonin 2A receptor and also reuptake inhibitor. And they antagonism also reduces the risk of anxiety, sedation and sexual dysfunction. Okay, and they are powerful 5-HT2A antagonists. Previously, we are blocking only the reuptake pumps or blocking the metabolism. They are also blocking the receptors. Mainly, these are trazodone is commonly used off-label for the management of the insomnia. So sleeplessness we can use. They are very much sedating, but this trazodone is lesser used now because of the two adverse effects. One is the priapism. Has been associated with the priapism. Priapism is the sustained contraction of the penis. That leads to sustained and painful contraction of the penis. That may happen with trazodone. That is known as the priapism. And hepatotoxicity is another important side effects of the trazodone. This is also important. These two adverse effects. And both of these agents may lead to orthostasis and dizziness also. That's why it is used lesser in some of the cases. But they are better suited for the elderly, or already you have seen. They can be used in some of the cases of the elderly. Mirtazapine is used more commonly in comparison to the nefazodone. they are presynaptic alpha 2 receptors antagonist. So presynaptic যে alpha 2 receptor টাকে তার antagonism করছে in addition to the antagonism at the 5-HT2 receptor. That's why they are known as the noradrenergic and specific serotonergic antidepressant. And this mirtazapine is very much sedating because of its potent antihistaminic effect. That's why those depression patients who have very high level of the insomnia, usually we are using the mirtazapine. Commonly use kora hoy mirtazapine. They does not cause any antimuscarinic side effects. The interaction with the tricyclic antidepressant or the sexual function is also very less. Increased appetite and weight gain can frequently occur. Otherwise, more or less similar. Mianserin blocks the presynaptic alpha 2 receptors, but just remember the name because it is lesser used now because of the blood dysphagia and liver dysfunction. It is not used, lesser used now, but this mirtazapine is more commonly used. Remember, when there is insomnia, depression, if it is associated with insomnia, we have to use the mirtazapine. Tianeptine is used mainly in the angiodepressive disorder. Just remember the name, details is not required. Vilazodone is the newer ones, used similar to that of the SSRI. Other SSRI যেখানে use করা হয়. Vortioxetine, just remember the name, another newer ones because the side effects are the lesser and used in the similar types of the cases. So these are the therapeutic uses of the antidepressants, what we are discussing. So endogenous or major depression, this is the first indication of the different types of the antidepressants. Depression, we have to start with the antidepressant drugs, already we are talking, and we have to wait for the minimum 2 weeks to 2 months, and then we have to add another antidepressants according to their side effect profiles or to see whether any interactions between these two is present or not. Or we can change the antidepressant drug if it is not occurring. Then the panic attack on acute episode of the anxiety, different types of the panic attack. There may be some social phobia or other types of the panic attack, acute episode of the anxiety, generalized anxiety disorder. These antidepressant drugs can be used in addition to benzodiazepines. Obsessive compulsive disorder, already we have discussed. Attention deficit hyperactivity disorder, this is mainly seen in case of the children and adolescents. Attention deficit hyperactivity disorder, again this SSRI is given. Chronic neuropathic pains or unexplained body pains. Now the first line of the drugs, this neuropathic pain is different types of the SNRI and then the SSRI. Usually the duloxetine or desvenlafaxine or venlafaxine is used. Then other SSRI like escitalopram or fluoxetine can be used. Fibromyalgia is similar to the chronic unexplained pain symptoms. This is known as the fibromyalgia where the antidepressant drugs are also used. Premature ejaculation, already we have seen different antidepressant drugs can be used premature ejaculation. Eating disorder, another thing, very important thing. So there are mainly not only bulimia nervosa, there are two types of the eating disorder is there. One is anorexia nervosa, another is the bulimia nervosa. Anorexia nervosa means the patient will not eat anything because of their false assumption that he or she is very fat, even if his or her BMI is less than approximately 15 or 16. So ultimately this anorexia nervosa, it is difficult to treat and ultimately the mortality is also approximately 10%. You can search in the internet and you will see that very many famous models have died due to the anorexia nervosa in the Western countries basically. And another is the bulimia nervosa. The patient eats bulimia nervosa, binge eating. They are doing some binge eating and then out of the guilt, they are just vomited out. Okay, so this is known as the bulimia nervosa, anorexia nervosa, bulimia nervosa. These are also treated by the different types of the SSRI. Most commonly the fluoxetine, sertraline, escitalopram and citalopram. Usually these are used and also counseling is required. Premenstrual dysphoric disorder. This is also common. Around the menstruation, there may be some dysphoria, different types of the, we have to use the different types of the antidepressant drugs. Enuresis, enuresis means nocturnal micturition. Mostly it is seen in case of the children and imipramine is still now used very commonly and very successfully for treatment of the nocturnal enuresis. Okay, so nocturnal enuresis, imipramine, which is a tricyclic antidepressant, is used. Migraine, you have already read about the migraine. So probably you have read na migraine, otacoids e porechiস. So there may be acute migraine, chronic migraine. কিছু কিছু ক্রনিক মাইগ্রেন যাদের ক্ষেত্রে মাইগ্রেনের অ্যাটাকটা বারবার হয়, if we are continuing with the antidepressant drugs, there are some antidepressant drugs that will leads to decreased frequency of the migraine attacks. So মাইগ্রেনের ক্ষেত্রে ইউজ করা যেতে পারে। pruritus, কিছু কিছু ক্ষেত্রে unexplained pruritus থাকে, বিভিন্ন জায়গায় ইচিং হচ্ছে, in those cases also this is due to the some neurotrophic factors that also we can use the antidepressant drug. So this is very important. What are the uses of the antidepressant drugs? So these are the different uses. So thank you. So this is all about the antidepressant drugs. Any question?